Hi everyone, welcome back to class. I hope you all had a wonderful summer break, but we are going to jump right in this week and start to get to know our manuals. This presentation is to assist you in getting to know the format and the setup of the store manual. We will go through some of these slides very quickly. I just want you to start to become familiar with this manual. I realize this is going to be overwhelming, but you do not have to memorize it, okay? That's very important. You should never memorize this information. Only get to be familiar with it right now. We're gonna learn each different section separately. So we will break it down in sections. Just right now, I just want you to understand the format of the entire manual. We will begin to use this manual in a couple weeks in the Abstracting Principles class. The first thing you need to know about STORE is that when you start to abstract cases, you will have the STORE manual open and you will read each data field description, its rationale, instructions for coding that field, as well as the code options. Before I forget, today, when I refer to the page numbers in STORE, I am referring to the STORE, the hard copy page itself, not the PDF page number. So if you can pull out your hard copy of the STORE manual, we will be going through pages, so it might be very helpful to have it open in front of you during this presentation. I do recommend that you use the hard copy of this manual in class, okay? It's just easier to add stickies, notes, and things like that. And we'll talk more about notes during our study group webinar this week. This presentation is on the long side, so please feel free to pause the presentation and take breaks. It's just easier to record the entire thing and you just to watch however much it is that you know, that's convenient for you, for your schedule. So STORE is the manual that contains all the data items with the data field description, rationale for collecting the data. Why are we collecting this data? It tells you. Instructions for coding the data field, the allowable codes, code definitions, and examples. STORE is used by cancer registrars in COC accredited programs. You may hear registrars refer to this manual as their Bible. NACER, the North American Association of Central Cancer Registries, has a manual equal to this one called the Data Standards and Data Dictionary Volume 2, which SEER programs use. We will review that manual at a later date, but for this semester, we will focus on using the STORE as required by COC accredited hospital registries. First, I am going to quickly go over each section of the STORE, and then we will get into each section in more detail. So just hang on and follow through, and just like I said in my welcome video, it takes baby steps to get to learn everything that you need to know to abstract. So after the table of contents is the preface. The preface explains what has been changed and or has been added to the new edition of the STORE. This summary is very, very important if you have used the STORE manual in the past. Since you have not used the STORE manual yet, please ignore this section. I don't want you to read it and get confused with what was, with what is, and you just need to know the what is right now. So please ignore this section. Section 1 explains how we determine if a case is eligible to be accessioned, abstracted, and then reported to the National Cancer Database, the NCDB. However, even though NCDB may not require these cases to be submitted to them, Your state central registry may require you to submit the case, in which case you would then have to abstract it and submit it to them. So it is very important to know what types of cases your state registry requires you to submit. And how do you know that? Well, the state has their own coding manual, and that's where you would find that information. Section 1 also reviews the overview of the coding principles of the store manual, which we will review in a moment. Now, Section 2 is the part of store that contains all the data items for the registrar to collect in the abstract. The data items are separated into different categories. The site-specific surgery code data field items, even though this is part of the first course of treatment, are not included in Section 2. Okay, we'll look at Section 2 in more detail in a moment. So the surgery codes have their own section in the store manual. Appendix A is the section that will list all the revisions and updates made to the store manual as long as it is in use. Since the manual is only in its first year of use, the appendix is very short right now. Appendix B is the section that contains the coding instructions and surgery codes for the different primary sites. The sites are listed in chronological order by their ICDO site code. So that's in order that they are. So you'll get to know how that order by site code as you become more familiar with abstracting. Appendix C contains changes introduced since the initial January 2010 release of the Ford's revised for 2010. This is just a running summary of changes over the years, so we can remember when something has been changed, deleted, added, or clarifications that were made to the different versions of Ford's by sections and then in chronological order. We will not use this section of the store since it is for historical purposes. So another section you can ignore. Appendix D is the listing of data items that must be completed in order for the date case completed COC data field in order for that to autofill in the abstract. We'll talk more about that in a future course, okay? It's just it's a list that you may have to refer to. Appendix E is a listing of country, state, and province codes. We will not be using this section this semester since we will be concentrating on the cancer data fields themselves. Let's review the book together. So if you have it there in front of you, open it to page 15, the first page of section 1. These are the rules we use to determine if a case is accessioned, abstracted, followed, and submitted to the NCDB. The tumors that are required are malignancies with an ICD-03 behavior code of 2 or 3 for all sites, with the 4 exceptions that are listed, which may be confusing to you because 2 are actually basically like not exceptions, but they are called exceptions. All right, so instead of thinking all of them as exceptions, I'll tell you which ones are kind of like not considered exceptions. Okay, so exception 1. So your rule is if the behavior code is 2 or 3, you report it, okay? And if it's not 2 or 3, then you won't have to report it. However, for juvenile astrocytoma is listed as code 94211 in the ICD-03 manual, okay? But this is now required to be reported, and it should be recorded as 94213 in the abstract, okay? So even though it's a behavior code of 1 in the ICD-03, manual, we have to report it, and it actually has a behavior code of a 3 now. Exception 2, effective with anyone diagnosed on January 1, 2015 with a carcinoid tumor of the appendix. It is required to be reported, okay? This type of case was not submitted in the past, but is now submitted with a code behavior of 3 and is no longer considered a tumor with the behavior of 1. So see what I mean? It has a behavior code of 3, and that's the rule, but it used to not be the rule. We used to have to make it a behavior 1, all right? So as you learn, when we get to know the ICD-03 manual, behavior 1 is defined as a benign tumor, and behavior 3 is defined as an invasive malignancy. So basically, then we go to exception 3, malignant primary skin cancers with histology codes 8,000 through 8,110 are not required to be reported by the COC. At one time, there were certain skin cancers with these histology codes that were submitted, but they are no longer required. But if you end up working for a registry that is collecting data from before 2003, they are still required to follow these cases. So if you have a skin cancer with the histology code of 8,000 through 8,110, you do not report those. And then exception 4 is carcinoma in situ of the cervix, or CIS, and intraepithelial neoplasia grade 3 of the cervix, also known as SIN3. And the other cases listed are not required by COC to be accessioned and abstracted. But these are the cases that some states do require a registry to accession and submit to them. That is why it is crucial that you know what the state requirements are as well as the COC. So to make this, short, sweet, to the point, exception 1. If you are coding and abstracting or have a patient with a juvenile astrocytoma, it is reportable, and you assign 94213. So that's basically what exception 1 is saying. And I don't think I ever, in over 20 years now, have ever had a juvenile astrocytoma, but it's something that we need to know, that if we have that case, we report it, and it has a behavior code of 3. 2, that rule is if you have a carcinoid tumor of the appendix now, we have to report it. We have to abstract it, and it is considered a behavior code 3 now. Exception 3, if we have skin cancers within those histology code range, we do not report it. It's as simple as that. And then exception 4, if you have a case with any of those listed conditions, COC says you do not report them. However, your state might. So there's a lot of words there, but basically it's yes, no, so make notes that help you know exactly what it is that they're saying. Then the rule for non-malignant primary intracranial and central nervous system tumors is stated. These tumors were not reportable until January 1st, 2004. The different sites with benign tumors that are required to be accessioned and abstracted are listed. These are the cases that are more difficult to find during case finding, just as an FYI. Just keep in mind that all cases that are abstracted are not all malignant cancers. There are benign tumors that we must collect, follow, just like malignant ones. And then obviously from our exceptions, we know there are malignant tumors that we do not accession and abstract. There's also a sentence here explaining when to report the gastrointestinal stromal tumors, better known as GIST tumors and thymomas. These tumors, which are often benign, are abstracted and assigned a behavior code 3 invasive cancer if they are noted to have multifoci or multiple masses, have metastasized, or have positive lymph nodes. So if you have a GIST tumor or thymoma, okay, and there aren't multiple masses, there's no metastases, and lymph nodes are not positive, you do not report that case. Reportable by agreement cases are cases that are not required to be reported by COC, but are required by your cancer committee. Okay, your cancer committee may decide they still want you to abstract and track these for their own purposes. Sometimes facilities want to track their borderline ovarian tumors. And as stated before, some central registries require the in situ of the cervix cases. So those are considered reportable by agreement. You have agreed to report them for a specific reason, but they are not required by the COC to do so. So the reportable by agreement would be this agreement between you and your cancer committee and you and your state central registry. If these cases are abstracted, there's a classic case 30 that should be used. This way they are easily separated out from your NCDB call for data, because NCDB does not want these cases, so they have to be assigned a different class of case code. Now pages 15 and 16 are going to be your best friends. All physicians use ambiguous terms at diagnosis. These two pages have a list of ambiguous terms that constitute a diagnosis and a list that do not constitute a diagnosis without additional information. At the top of page 15, the ambiguous terms that constitute a diagnosis is listed. Make sure you notice that the word neoplasm is used for the diagnosis for sites listed only. And those sites listed are the CNS and the intracranial tumors. So the word neoplasm is only associated with the CNS and intracranial sites. There is also an exception listed for cytology. If a cytology is identified only with an ambiguous term, we do not interpret that as the diagnosis of cancer. Abstract that case only if there's a positive biopsy or a physician's clinical impression of cancer supports the cytology findings. This happens very infrequently. There are a couple of examples of diagnostic terms so you can get an idea of how these terms may be used in the medical record. At the bottom of page 15 is the list of ambiguous terms that do not constitute a diagnosis without additional information. Examples are also given for this list continuing on to page 16. Page 18 has additional clarifications about class of case that are not listed on the pages where the class of case data field definitions, codes, and explanations are given. So these rules may not make much sense to you right now. Right now, what you need to know about this page is that class of case codes 0 through 22 are considered analytic cases, in which the patient was diagnosed and or received part or all of their first course treatment at your facility. Class of cases 30 through 99 are considered non-analytic and are cases that are not required by the COC and are usually cases that the patient was diagnosed and had all their first course of treatment at a different facility and have come to your facility for a recurrence of that same primary. Then comes the modifications that were made to the classic case data field in 2010. This was basically a clarification for a better understanding of how the classic case determination changed in 2010. This key to this the key to this statement is that treatment in the staff physician office is coded as treated elsewhere, even if that physician is on staff at your facility. Their physical physician office is considered elsewhere when looking at classic case. The remaining information on pages 18 and 19 explain in more detail the rules of recording the date of first contact. This is, once again, additional information that is not written in the field description and purpose later in the manual. So you may have to, move these pages or place it after the data first contact data field. You could make a copy of this page, keep it where it is, but make a copy, and then insert it after the data first contact, so that information is in both places if you want. Because sometimes we forget that information there's additional information in the front of the manual. The date of first contact is the date that the patient was diagnosed or treated with cancer at your facility. This may be an inpatient or an outpatient encounter. Usually the date of admission for the diagnosis or for the treatment of the cancer is the date of first contact. However, sometimes a patient is admitted to the hospital for non-cancer related problems. Then the cancer is found on a day or two after their admission. The date of first contact for the abstract would be the date they suspected that patient of having cancer or were diagnosed with cancer, which may not be the admission date. So the date of first contact is not always the admission date. Now, page 20 starts the overview of coding principles that you need to know, but are not necessarily included in the field-specific information throughout the manual. Once again, it's additional information, that if you want that information where that data field is discussed, make a copy and put it in that section of the store. This section explains the importance of an accession number and why an accession number is considered a unique patient identifier. It also explains that using NPI or National Provider Identifiers for facilities and physician makes it easy for reporting as those numbers are consistent throughout the United States. Turning the page, the coding date section explains how the format of dates was changed in 2010. Don't worry, software companies have made it easy for us. We actually enter the date the way we always have, month, date, and year. And when the data is exported to the state and NCDB, the software converts the date to the format that is required. So whenever a data field says this, the format goes year, month, day, we do not enter it that way. Okay, we enter it like you normally would write it, month, day, year, and it gets changed for us. Under the cancer identification section, There are instructions that registrars need to remember and must follow for consistent analysis of primary sites for particular histologies. There is also a table to assist in coding for specific tissues with ill-defined sites. These cases are not common, so they write it in the coding principles just to remind us of these rules. For the rest of page 23 and 24, the sites that have laterality are listed for easy reference. For the most part, laterality is common sense, but some sites, such as skin, we don't normally think of having laterality, however, they do. So that table just tells us when we, have to code right or left. At the bottom of page 24 onto 25 is the revising the original diagnosis. This explains that anytime you find additional information on a patient's abstract, it can be and should be revised, even if it's a year later. There is no time limit in making revisions that give better information about the original diagnosis or stage. Examples are given for you to have a better understanding of this concept. Of course, there has to be coding principles about the patient's address and residency, which is next. These guidelines assist in making sure that we have consistency across the board, okay, for those patients that may have more than one home, may be incarcerated, or in the armed forces. Beginning in 2013, country and state fields were added to the addresses were recorded. So the guidelines on coding country and state were written to help us better understand these new data fields. So some of these things, you may forget that that information is there. It may be, 2 years before you have a patient that's incarcerated, then you'll say, oh, how do I record that? That information is there for you. So just don't forget about section 1. On page 27, there's a paragraph pertaining to utero diagnosis and treatment. It explains how this is very rare, but it can happen. In fact, I did have a case like this years ago. Sometimes a fetus or an unborn baby will be diagnosed with cancer prior to birth. Before 2009, we had to record the diagnosis date as the date of birth. But in 2009, they changed that, and we now record the date the fetus is actually diagnosed, and sometimes even treated for that cancer before they are born. So their date of diagnosis and their date of first contact, their date of treatment might actually be before their birthday. Then we have the principles about coding comorbidities and complications. These principles over the 3 general categories of information that we need to collect are comorbidities, complications, and factors that influence the health status of patients. This section also explains that as a case is diagnosed January 1st, 2018, only the ICD-10 CM codes should be collected. So we will be doing cases that are older than 2018. So make sure you go to the ICD-10 section. Don't use the ICD-9. In fact, if you want to take the ICD-9 pages out, set them aside, put them in a file folder, you would only ever have to refer to those pages if you were doing a case that was 2017 or earlier. And we won't be doing any of those cases in class. Now, page 28 continues with the coding principles of stage of diagnosis at initial diagnosis. These are just general rules about staging, and that the AJCC manual should always be used and reviewed for coding these fields. Remember, the STORR manual, it's a data dictionary. It's a listing of every field that we have to record. but that the store manual itself doesn't necessarily tell us how to code that data. There are times we're going to have to refer to a different manual to assign the code for that data field. There's a table on page 29 with ambiguous terms describing tumor spread. Do not use this table when you are AJCC staging, all right? That they do not correspond with each other. Page 29 starts with coding principles of first course treatment. It explains what types of treatments there are, what a treatment plan is, the time period for first course of treatment, and other specific principles that we must know. We will read these pages in the future and get to know all these principles better. So of the information in the overview of coding principles is also included on the pages of the site, the specific field information on it, but sometimes it is not. So you'll get to know when we do each section. I will point out to you that, yep, these pages in the front also pertain to the data fields. So you'll know that you need to read both sections. And if you would rather have that information and by that data field, then make a copy of that page and stick it behind that data field. And we'll talk more about tabbing manuals and things like that. So hang tight for that. Oh, sorry, I missed switching my page there. All right, on to section 2. Instructions for coding starts on page 45. Let's go to page 49 so we can look how each field is actually formatted. As you can see, page 49 is the field sequence number. The first thing that is listed under the title of the field is a description of the field or answers the question, what is this field? All right, it explains exactly what you are collecting for this data field. Then there is the rationale. Why do we collect this data? All right. We always want a reason why data is being collected, because if there isn't a reason, there's probably not a reason to be collecting it. Then there are instructions for coding this data field. The first part of bullet 1 states, codes 00 through 59 and 99 indicate neoplasms of malignant in situ or invasive behavior, behavior 2 or 3. 2 is in situ, 3 is invasive. This means if you have a malignant case to abstract, the sequence number should be a number 0 up to the number 59 or 99. I've never had to assign anything over 10 for a patient, so hopefully you'll never have to assign 99 for a patient. The codes that are valid for each field are listed with the definition for that code. Now, sequence 00 means this patient has only one malignant or in situ primary in their lifetime to date. A 01 would be the first of 2 or more independent malignant or in situ primaries. Then there is a table with the non-malignant primary sequence numbers using the same concept. Then there are examples listed with the code and the reason that field should be assigned that code. Now, if we go to the top of page 49, you will see a table of information, and that same table is on this slide. Some of this is very important, and some is just information. First, it states the NACER item number of this data field. This is important when it comes to edits, okay, which we will learn more about next semester. For right now, just know that it is there for your reference. Every data field has to be numbered, okay? So that's this data field number. Then it tells you the item length of that field. This field has a 2-digit link, which means it will not allow you to enter a 1-digit code or a 3-digit code. You are only allowed to enter 2 digits for that data field. Now, unfortunately, there may be data fields that will actually allow you to enter 3 digits. However, the field doesn't, that would be incorrect. It's just basically telling you for this field, it needs to be a 2-digit number, all right? It tells you the column numbers for this data item. This is so you know where to find this information when the data is exported to NCDB or the state. Don't worry, unless you work with software or editing program, you don't need to pay attention to this information. It also tells you the allowable values for this field. Now for this data field, only codes 00 to 89 or 99 can be entered. If something else is entered, you will get an edit error, all right? So the allowed values is very important to pay attention when you are assigning a data field code. Next is the years that that data item is required to be recorded. This data item sequence number must be collected no matter what year the patient was diagnosed with their cancer. Then the revision dates are listed. A date is listed every time this data item has been updated or revised. So this format is used for every data field in the manual. So what's really important for you to pay attention from this table at the top is the link, how many data items or digit length the data field wants you to enter. And then the allowable codes those are the codes that you can and should enter in this field. Anything that's not listed, it won't be right and you'll get an edit, all right? And then required years that you may have to pay more close attention to when and if you have to abstract old cases. So for now, really pay attention to the link and the allowable values. So let's go to page 46, where the patient identification fields begin in section 2. The items that are listed on this slide and the next are the patient identification fields, fields that pertain to the specific identification to that patient. You will read these pages in the future in the Abstracting Principles and Practice 1 course. Something to note. The comorbidities and complications were the data items where we collected the ICD-9 diagnosis codes that were recorded in the medical record. Now facilities are using those ICD-10 codes. So as I stated earlier, we need to make sure that we go to the secondary diagnosis pages in the store manual to follow the correct coding instructions. ICD-9 and ICD-10 codes were recorded very differently. So if I have taken my ICD code, the ICD-9 codes, the comorbidities and complications out of my manual so I don't, I don't accidentally use them. So we need to assign the ICD-10 codes from the secondary diagnosis section. These are the cancer identification fields. There is a definition and rationale for each field. The cancer identification data fields begin on page 121. And these are the fields that we're going to be learning and abstracting over the next semester and into next semester. There are times that the store manual will list a data item field that is collected, but the instructions for coding that item is found in a different manual. Remember when I was talking about that earlier, like with the AJCC staging. So here's an example. For the grade data items that start on page 139, it tells you that you need to use a different manual to assign codes for these items. They do list links within the store manual. However, I would not use these links since these manuals can easily be updated and revised after the store is published. So as you can see, it's a PDF file that they're linking you to, but that PDF file may have been updated since the store manual was published. So always just have that manual, the current version, access to that, whether it's a hard copy or on your desktop, and just make sure that you refer to that manual when need be. All right. The stage of disease at diagnosis data items began on page 145. These data items pertain to the diagnostic procedures that are performed on the patient, as well as if there is lymphovascular invasion of the tumor. Then we get to the sentinel and regional lymph node data items starting on page 157. Not only is it important to record how many lymph nodes are positive, but also how many lymph nodes were examined and the type of lymph nodes that were examined. So we will get into these data items in more detail later on this semester. Then we get to the tumor size and METS data items. Tumor size is usually used to assign the T of the AJCC T&M stage. METS at diagnosis is used to assign the M of the AJCC T&M stage. On page 190 is the description, rationale, and allowable codes for the summary stage 2018 data item. Once again, you must go to the appropriate chapter of the summary stage manual to assign the correct code. So in our store, the store is a data dictionary. It's saying we have to collect the summary stage. This is, the general rules. However, go to that manual to assign the correct code. There are instructions for assigning AJCC 8th edition, but remember, once again, this is a data dictionary that lists all the data items that are to be collected in an abstract. However, we would go to the AJCC T&M manual, the textbook, and follow those rules to assign all the T&M data items, which you can see and are listed here. There are many. On pages 229 and 230, there is a list of the site-specific data items that the COC requires accredited facilities to collect for all abstracts. Basically, once again, we will ignore these pages of the store manual and use this corresponding manual when necessary. So there is a site-specific data items manual that we need to go to when assigning those codes of the abstract. First course treatment starts on page 231. The next several slides list the fields that are considered part of the first course of treatment. Of course, all these fields may not be used for every abstract. For instance, some patients are never admitted to the hospital for their diagnosis or treatment of cancer. Therefore, they would not have a readmission to the same hospital within 30 days of surgical discharge. So this data field would be left blank. So even though, these data fields are listed in the data dictionary, we may not have to assign a code to them. Not all patients will receive radiation therapy, therefore you would not have to fill in all the radiation data fields. However, there are some radiation data items that must be collected even if radiation was not given to the patient. And when we begin to abstract, your assignments will tell you exactly what data items you need to collect. So it's not going to be as difficult as it's sounding right now. Radiation therapy is also collected in phases, which you do not need to know right now. There are data fields to collect 3 phases of radiation therapy. Most patients only receive 1 or 2 phases of radiation, and you'll notice that the data fields for each phase are exactly the same. And since this is a data dictionary, phase 1, phase 2, and phase 3 have every one of those data fields repeated, okay, because each of those data fields has its own item number, okay? So there's a lot of pages there that you might not use very often in the STORE manual. Some you use every single time you abstract, others you'll be able to skip over. There are even data fields to describe the sequence in which a patient received treatment. For instance, systemic surgery sequence. Did the patient receive the systemic therapy, the chemo, immunotherapy, the hormone therapy before or after surgery? Or they can sometimes even be given it before and after surgery. Or was there no systemic therapy or surgical procedure done? Data fields like this can make running reports less cumbersome. So that's why it's easier to run reports on this type of data field than it is on a treatment field. You do not need to memorize the different types of treatments. For right now, just know there are a lot of ways to treat cancer, including palliative care. And we collect and record all treatment, even if it was not done at the reporting facility, your facility. On page 385, the outcomes data fields begin. The outcomes include tumor status. Has the cancer recurred after being disease-free? And what type of recurrence was it? The patient's cancer status is the patient with or without cancer. Some patients are never disease-free. So a patient can with cancer or with disease, without cancer, or never disease-free. Of course, we must collect the date of last contact that we know the patient was alive or their date of death. The patient status is the patient alive or have they expired? It is important to make sure we have the patient's vital status accurately recorded, since this is taken into consideration when running follow-up in other reports. There are also data fields to record where the follow-up information was obtained and the source that will most likely be used to obtain future follow-up information. So that is what we consider the outcome section or the follow-up section. The case administration section starts on page 400. A lot of this information on this slide and the next is behind the scenes and is pre-filled information. So you don't have to assign codes for this. They are done for you. The data field that you must fill in and complete yourself is abstracted by, which is your initials. This verifies that you completed the abstract and the date in which you did it. We will use this section next semester when we talk about edits. But right now, you know, it's really a section that's behind the scenes. And the data fields listed here are also pre-filled. Your software vendors, they make these things easy. They write their code so that these things are auto-filled for you. Appendix A includes the updates that have been made to the store manual since 2018. Since this manual was only published a year ago, it only has 1 page in length. So not many changes, but you never know, come January 2021, there may be changes. The store is an evolving data manual. To ensure changes are clearly defined and tracked, Appendix A records all changes, revisions, clarifications, etc. So it's just a tracking. Appendix B, site-specific surgery codes, starts on page 439. This is the section where we get the surgery codes for each primary site. At the top of the page, it states the site with all eligible site codes that you would use these surgery codes for. The histologies that are listed would be histologies in which you would not use those surgery codes. So if there's a histology code, they're listed, and that's the histology that your case is, you would not use those surgery codes. So just make sure that the except for that is stated, okay? So it's kind of weird that, you know, it's the opposite, but just note the except for. You may want to highlight this to remind you why these are listed, okay? Codes are listed with a description of the procedure. NOS codes, the not otherwise specified codes, are listed first, with the more specific codes indented and listed under the NOS code. Let's go to page 468. This is where the breast surgery codes begin. If you go down the page a little, you will see code 40, total simple mastectomy. This is the NOS code that would be used if you did not know if the other breast, the contralateral breast, was removed at the same time or not. More often than not, you know this information. So code 40 should not be used, you know, often at all. And never use those NOS codes unless you have to. If a patient was BRCA positive, BRCA positive, the standard of care would be bilateral mastectomies, even though there is no cancer in the other breast. So if your patient had bilateral mastectomies without reconstruction, you would assign code 42. If the patient had bilateral mastectomies with implants placed for reconstruction, you would use code 49. This is an example of how the surgery codes work. We will do an assignment on surgery codes later in the semester. Appendix C includes all fields that must be completed in order for the COC date case completed data field is auto-filled. So if the date case completed is blank, then that means you most likely forgot to record something in one of the data fields that are listed. All right, so that's where that list becomes important. If that date that you completed that case is blank and it's not auto-filled, it means you are missing something. Appendix E is the county and state codes of birthplace. On the first page, 514, the preferred geographic areas specific codes to use are listed when the details are known. And last but not least, the codes that are obsolete and must not be used. So actually, in class, we won't even have to worry about country and state codes because we're not going to assign any addresses. So we are really going to stick to the cancer data fields themselves, not the demographics such as birthday and addresses. Now I know that was fast and furious, get to know the store manual. Don't worry, we will learn this manual in small sections. We actually won't even get to some of these data fields until next semester, but I wanted you to get an overview of the entire manual. Now you are ready to complete the discussion forum and your assignment. If you have any questions about this presentation, please go to the virtual office and submit a question. No question, once again, is stupid or too minor to ask. If you have the question, I am sure someone else has the question, but just keep in mind that this is just an overview of the manual from 5,000 feet off the ground, okay? You don't have to read the whole thing. We will read it in sections. Remember, abstracting, to learn how to abstract, it's baby steps, okay? And this semester is going to be full of baby steps, all right? Once again, welcome back to school. Hope you all have a great first week of class. Take care.